examiner that, okay, whenever you're conveying this idea to the examiner that you're not, you're not shaken, you're not worried, you're not panicking, and that you're really calm and confident, I think this is one of the major issues that made many people pass the examination rather than having all the information and everything and keeping talking all the time, okay? So this is my simple point of view after passing the Viva. Try to be confident as much as you can. Keep your voice at the same pace. Also, one more thing, which I myself found very useful in the examination, is that try to sympathize with the patient. Okay, so for example, I had a case that was an osteomyelitis, and it was a child, and it was passing the epiphyseal plate, and so I got so concerned. I told the examiner, "Oh, I'm really concerned that this is a young child, and that it's crossing the physeal plate, and this might later on lead to a disability or a difference in the limb length. So I'm emergently going to pass this to the physician, you know, but show the examiner that you're really sympathizing with the patients, that this is how you will act in real life." So believe me, this is not an examination of how much you know radiology. It's how clever you are to make the examiner feel that you are so safe and you're so confident and like, "Oh, I've seen these cases a million times before." Okay? I hope you got.
Thank you. Yeah.
I will start the screen share, okay?
Sure, sure.
Okay. So who's the first candidate?
Dr. Mahak?
Yes, I'm ready.
Okay, you ready? Great. So you can see my screen?
Yeah, I can see.
Excellent. I'll just give you the remote control.
Okay.
Okay. All the best. Before starting, just put in your mind, I want to see as much cases as I can. And this is a very good policy in the examination. Anything that you feel that you're not going to go further than that, or you're stuck in it, just move on. Okay, I will just refer. For example, just not to consume the time, and no worries, I'll give you the 3 minutes in the end extra. In the examination, I had a case that I was really confused about. It was a pediatric x-ray, and all of us got so confused. So in the end, I just told the examiner, okay, I'm not a specialist pediatric radiologist. So in my usual practice, I will simply refer to a senior pediatric radiologist, because I'm really concerned about this x-ray, and I'm sure that there is something abnormal, but I'm not really that specialized. So in real life, they would go like that. Actually, I felt like I was gonna fail this Viva, but thank God I didn't, and I got a very good mark. I remember one of the Vivas I took like 7.5, and the other one was 6.5. Okay, so let's start this case. It's an 85-year-old male patient with abdominal pain.
Okay. This is contrast enhanced CT of abdomen. I'm scrolling craniocaudally. I can see there is minimal right-sided pleural effusion with basal consolidation, and I can see nasogastric tube, and there is, massive ascites. There is gas in the portal vein branches, and there is, I can't scroll actually very. There is massive ascites. I can see multiple hypoenhancing lesions in the liver. As I'm scrolling down, I can see free gas in the abdomen and along the falciform ligament, indicative of pneumoperitoneum. Bilateral kidneys and pancreas, they appear normal to me. I'm looking for the cause of pneumoperitoneum and gas in the portal vein radicals. As I'm going caudally, I can see there are multiple dilated loops of small bowel, and there is intramural gas in between in some of the loops, suggestive of pneumatosis coli. There is a background of atherosclerotic changes. Dr. Maha, can you scroll for me? Actually, I'm finding it a bit difficult and it's slow on my side.
It's okay, just let go of the mouse.
Yeah, I did.
Okay.
And there is a displaced fracture of the right neck of the femur with adjacent calcifications and soft tissue swelling.
Mhm.
And
Just
I'm looking,
concentrate on the abdominal findings.
yes. I'm looking for the cause, and I see there's a transition point in the left iliac fossa.
Mhm.
So the findings here are suggestive of bowel obstruction with ischemia and perforation.
Mhm.
I'm looking around the duodenum to see if there is any perforated ulcer.
Okay.
Okay.
Okay, so can you summarize the case?
So this is a case of small bowel obstruction with signs of ischemia and pneumoperitoneum. In my routine practice, this is a surgical emergency, so I would immediately inform the on-call surgeon since it needs immediate attention.
Yes.
The spleen, I guess it's arterial phase, the spleen is normal.
Yes.
I'm not able to find the cause of it. The liver lesions, they appear routine hepatic cyst, however, they need follow-up with ultrasound.
Okay. So what do you usually do if you're looking for a cause?
I look at the common causes of the small bowel obstruction and would see a
That's
transition point. Routinely, I look at the hernial orifices, and it could be because of adhesions.
Mhm.
And I would inquire about the previous surgical history if patient had any surgery in the past. The hernial orifices I looked through, but there was not any hernia.
Yes.
So I'm looking for any other cause, like since it's an old patient, any tumor which might be causing obstruction, but I couldn't find.
Okay, so how would you manage the case in the end?
So I would immediately inform the on-call surgeon since it's an emergency.
Mhm.
And yeah.
With a view forward that this patient will go for laparotomy, okay?
Yeah.
So let's move on to the next case. So this is your next case. It's a 25-year-old female who's presenting with seizure and confusion.
Okay.
Shall I scroll?
Yes, please. Thank you.
Okay, no problem.
This is non-contrast CT scan of the head. As I'm scrolling craniocaudally, I see there is hyperdense areas in
Why don't you take a look at the scan just entirely and then start?
Yeah. Okay.
Okay, I'll move slowly and you take a look and tell me whenever you want me to stop.
Okay. Can you please stop in the region of the basal ganglia?
Okay.
Okay. So there are diffuse bilateral symmetrical hyperdensities in the region of thalami, and I can see there is hyperdensity, linear hyperdense structures in the midline. So this is a non-contrast enhanced scan. I believe there is thrombosis of the internal cerebral veins leading to bilateral thalamic infarcts. So in my routine practice, I would proceed with CT angiography or MR angiography, venography basically, to see the veins and any filling defects in them. And there is dilatation of the temporal horns, suggesting there is development of early hydrocephalus. So I would immediately inform the neurosurgical team also. And if the patient is still on the table, we can do a cytovenography.
Okay. So we went for an MRI.
Okay.
Which sequence would you like to start with?
T2. And,
T2.
okay. I can see T1. Okay. This is MR brain. The TT sequence shows hyperintense areas in the region of bilateral thalami. Mixed heterogeneous hyperintensity is there, and which appears to be hypointense on T1. In my routine practice, I would correlate it with the SWI images to see if there is any hemorrhage. Yeah, there is hemorrhage in the SWI images in bilateral thalami, and I would look at the MR venography to corroborate my findings of deep venous infarct. Okay, there is filling defect in, there is non-visualization, yeah, of the internal cerebral veins and the vein of Galen and the straight sinus, I believe also on MR venography. So this is a case of deep venous thrombosis leading to bilateral thalamic hemorrhages, and the differentials here would include, like if there was only MR, would include artery of Percheron infarct also, but since it is very much clear on the MR venography that there is non-visualization of the internal cerebral veins and the vein of Galen and straight sinus.
Okay.
And so I would immediately inform the neurosurgical team and would alert my...
Can you just tell me what's your final diagnosis? Just wrap up the case first and then move on to the management.
Yeah, this is a deep, this is bilateral thalamic hemorrhages secondary to deep venous thrombosis. And I would immediately inform the neurosurgical team and also alert my interventional radiology colleagues with a view to anticoagulation and further management.
Okay, great. So what's the percentage that venous sinus thrombosis may cause a hemorrhagic infarct? Is it common or uncommon?
I've seen few cases, I guess 30 to 40% times it causes hemorrhages.
What are the common sites for venous sinus thrombosis if they cause a secondary infarct, hemorrhagic infarct?
Like if the thrombosis is in superficial venous system, they are commonly in the parafalcine region. And if the thrombosis in the deep venous system, they are common around the thalami.
Okay, excellent. Let's move on to the next case. Okay, so this patient is, let me remember. Okay, so this is a 75-year-old male patient who's presenting with chest pain and some tightness. He came for a chest radiograph. Okay,
this is frontal chest radiograph of an adult patient. I can see osteoarthritis at the humeral joints, and the most striking abnormality here is a rounded soft tissue density, radio density projected in the left lower zone, which has sharp lateral margins, but on the medial aspect, it is obscuring the left heart margins on the inferior aspect. And now I'm looking at the lung fields, bilateral lung fields, they appear clear, and there are no effusions. There is no, I'm looking at the bones appear normal to me. So I believe this is an anterior mediastinal lesion or a pericardial lesion, which is causing obscuration of the right heart border. The other differential, since it is ballooning out, my differentials would include a pericardial cyst, left ventricular aneurysm here.
Does it really give the density of a pericardial cyst?
No, actually it is slightly dense. It is dense.
Yes.
Yeah, I believe. Okay. Yeah, so it could be, sorry.
So you mentioned it's an anterior mediastinal lesion. Do you think?
Or it could arise from the pericardium, or it could be a left ventricular aneurysm, since I can see this, the left heart border is, in the apex is lifted upwards.
So what if I show you the lateral radiograph? Would it add any information to you?
Okay, it doesn't appear to be a left ventricular aneurysm. Actually, it is in the middle mediastinum, and
where's the heart? Where's the heart? The heart lies in which mediastinum?
The heart lies in the middle mediastinum.
Okay, so where do you think the lesion is?
It could be, it is in the middle mediastinum.
Okay, so do you think it has any connection to the heart?
On this image, I don't believe so. It could be, yeah, it could be a left ventricular aneurysm, which is superimposed because it's a 2D projection.
Yes.
Yes.
Can you actually demarcate the left heart border from this lesion? Or is it merging with it?
Yeah, it is merging with it on the lateral aspect.
I'm not sure if it's projecting really well, but you can see that there are linear calcifications along the base. Okay. So
Okay.
what do you think that is?
So it is a left ventricular aneurysm or a pseudoaneurysm. So in my routine practice, I would perform echocardiography
Yes,
of the
excellent.
patient.
But you have to tell me if it's an aneurysm or a pseudoaneurysm, because these two entities are totally different and they have different positions when they occur. So tell me, where do you usually see an aneurysm and where do you usually see a pseudoaneurysm? How would you manage an aneurysm and how would you manage a pseudoaneurysm? Which is an emergency? You need to call the...
Actually, left ventricular pseudoaneurysm, they can occur post-MI, post-myocardial infarction, and they are found. They have routinely, if they have a wide neck, they show areas of hypokinesia. So I believe, and if there is thrombus within the aneurysm, then it becomes an emergency because it can emboli to other parts of the body.
Yes.
So yeah, so on echocardiography, it will be clear that there is presence of any thrombus in the
Do you
aneurysm.
think that this is an emergency, or would you just convey that it's just to go for a
I would convey the findings. I would convey the findings to the referring clinician and would recommend echocardiography for the same. Yeah.
Okay, great. Let's move on. So this is a 55-year-old patient who's presenting, she's a female, and she's presenting with left hip pain after a car crash.
Okay. This is pelvic frontal projection of the pelvic radiograph, including both the hip joints. I'm tracing the cortices. Here I find that there are acetabular margins on the superolateral aspect. They are the cortex is disrupted on the superolateral aspect on the left side of the acetabulum. I'm looking for the other bones. The right hip joint, it appears normal. And
this is the right, if we'd like to take a look, and this is the left side, just a dedicated view over the femur.
Yeah, so I believe there is cortical disruption and irregularity around the left acetabulum here. Yeah, and there is, I believe there is lucency here. So it could be secondary to some other lucent lesion. And there are some small little lucences in the left femur and the shaft. I don't know if they are projectional or...
Just ignore the femur.
Okay.
Please concentrate on the left iliac bone. So tell me what you see exactly. Full description.
Yeah. So there is a lucent lesion around the acetabulum in the left iliac bone, and it is causing cortical disruption at the superolateral aspect of the acetabulum. It has a wide zone of transition. I can't see the margins very well.
Okay, Dr. Mahek, I need you to just trace it for me. I'm not sure if you still have the remote control. Yes, you have it. Please trace the lesion.
I believe here.
I can't see your mouse. Just click on the image and then...
Okay,
yes,
sorry.
Yes.
Yeah, excellent. I believe here.
Okay, just leave the mouse for a minute.
Okay.
What do you think of this area?
I just thought it was bowel.
And the bowel is like this.
Yeah.
Here, and the bowel is over here, but you can see a margin over here, and there are like bubbly lucencies, right?
Yeah,
so,
yeah. Okay. Sorry about that. Okay, so there's a lucent lesion in the left iliac bone with sclerotic margins, and there are thin septations in it, and it is extending.
What do you think about the zone of transition at this point?
The zone of transition is quite clear. It's a narrow zone of transition, and there is no aggressive features here, but since there is cortical disruption, so I'm concerned about the aggressive.
She had a car accident.
Yeah, so it could be like a fracture overlying this lesion.
So what would this lesion be? And kindly summarize the case.
Okay, so this is a non-aggressive lesion involving the left blade of the ileum, and it is causing there is a pathological fracture, I believe. And my differentials here would include giant cell tumor and any aneurysmal bone cyst. So I would like to do MRI of the pelvis to further evaluate the lesion.
Okay, so the patient arrived at an emergency hospital and stuff like that, and they couldn't do an MRI, so we just went for a CT scan, okay? So I'll just show you the CT. I'll show you the portovenous phase, the soft tissue window at first, okay? Just take a look at the images and then start to report.
Okay. All right. Okay, so there's lytic destruction of the iliac blade involving the iliac on the ilium bone along the sacroiliac joint also. And there are cortical breach at various places, and there, however, there is no associated soft tissue with the lesion.
Are you sure? Just notice the marrow here.
Yeah, there is expensile. Yeah. It is expensile and there is soft tissue. Yeah. And there is cortical disruption at various sites.
So would this change your differential? Can you remember the history of the patient? How old was she?
Like she was 80 years, I believe. Yeah, 85.
Right.
Yeah,
so would this change your differential?
Yeah, this could present a metastasis, or it could be because of myeloma or lymphoma, but metastasis would be my primary concern. So I would do a CT staging for the same and would inquire any previous history about bone neoplasm or any breast or lung cancer. And if this patient has presented with this finding for the first time, a staging CT could be organized, and I would urgently inform the referring clinician about the same. First, the patient need to be referred to the orthopedician for the immobilization and fixation of this, and then the discussion at the oncology MD meeting could be done.
Excellent. Okay, I think we can stop here. I think you did very well. I like that your voice is confident, you're calm, and these are, I think, one of the two things that are very important in the examination. So let's start the feedback from this case. I think you went through 4 cases, and this is very good. Just always aim at 4 to 5 cases in each Viva. So when you're coming out of the examination, after your 4 Vivas in the exam, if you've been able to see about 18 to 20 cases, then this is relatively gonna be awesome. And I didn't know anyone who has gone through that number of cases that didn't pass the examination, okay? So if you're going for each Viva 5 to 4 cases, this would be excellent, okay? So let's start with this case. This case, you're absolutely correct that this is the lesion on the plain film, but it has a narrow zone of transition. This is very important. You can actually, like window the image and stuff like that, but in the examination is not that recommended. You can, usually they put on the image that is the most clear, okay? So there's no need to window the image if you're not able to see the lesion, because probably if you window it, it will make it just less clear, okay? So in this case, the patient, it was just an incidental finding. They found that this lesion was discovered after she had this car accident, okay? And you've mentioned the management very well. The point is that it's an emergency, it's a fracture. I have to refer the patient to the fracture clinic. They will have to immobilize the patient, as you mentioned, and then with a view for that this patient might need a biopsy because we really don't know what's going on. When they did the biopsy, they found that it was a plasmacytoma. So just remember that you need to, as you have considered metastasis, you have to consider myeloma, and then tell them, okay, I will also add the workup for myeloma for this patient, which are the Benz-Jones proteins and the skeletal survey and the stuff like that, okay? So just remember always to add myeloma, especially in the old ages, and mention that the workup, okay? Just, you can even say myeloma workup, just to show that you know it, okay?
Right.
So this is regarding this case. We'll just go back. The previous case, okay, this is one of the straightforward cases that you can, you know, like score an 8 in it. Simply, it's a left ventricular aneurysm, okay, and it's projecting over the apex. So it is a pseudo aneurysm. Usually, when it's the clue here is the lateral radiograph. It's at the beginning here, you feel that it's coming off the apex, but then when he gives you the lateral radiograph, you can see that it's projecting posteriorly, okay? If you go back to the differential of a pseudoaneurysm and an aneurysm, you will find that the aneurysm is usually something that happens along the apex of the heart. If it's a true aneurysm, it can be due to a previous transmural myocardial infarction. However, a posterolateral aspect, which is in this case, is usually a case of a pseudoaneurysm, okay? Another good thing here is that you can see that it has a wide mouth, okay? It has, it has a wide neck or mouth, okay? In the other way around, you will find that it has a narrower neck, okay? The point is here is that you have to decide whether it's an aneurysm or it's a pseudoaneurysm. It is a pseudoaneurysm, and so this is an emergency because it might rupture anytime. It's a contained rupture. Okay, it's only confined by the hematoma or the organized hematoma surrounding it. So this is an emergency, okay? You might be asked about the complications and stuff like that. Okay, as you said, you mentioned very well, the might happen a mural thrombus, might be that the patient will have heart failure, will have arrhythmia and stuff like that. So this was very good. But anyway, just remember the differences between an aneurysm and a pseudoaneurysm and how to pick it up. This case was excellent. I think you did very, very well. You picked up the abnormality very fast. You said that I can see that there is a hyperdensity along the midline, and this is the region of the internal cerebral veins. There is also some hyperdensities within the hypodense thalami, which means that this is a hemorrhagic infarction. I just wanted to hear the terminology of hemorrhagic infarction, okay?
Right.
So it's a hemorrhagic venous infarct, okay? So the good thing is that you moved on right away to, I will go for an MRV or for a CT venogram because I want to exclude that there is a venous sinus thrombosis. So in this patient, they also had ventricular bleed as well. You didn't mention that, okay? So there was some intraventricular bleed. There is also hyperdensity within the internal cerebral veins. When we moved on to the MR venography, you correctly mentioned that it's the straight sinus and as well as the parts of the transverse. And here it's also, you can't see the inferior petrosal, right?
Yeah. Right.
The inferior sagittal, I mean, so this is the superior sagittal and this is, where is the inferior sagittal? It's not there. So it's all in the region of the deep cerebral veins, okay? So this case was really good. You did very well. This is a classic, you know, like they say, a textbook case in which you find all the findings of the ischemic bowel. You correctly mentioned that you're looking for a reason, but you can also see that there is extensive calcification within the arterial system and that this patient was an 80-something-year-old, okay? So probably it is something like a detached thrombus or something that you might not be able to see here on this CT, okay? So the point is, mentioned that there's portal venous gas, right?
Yeah.
I think we did. And when we move downwards over here, you can see also that there's superior mesenteric venous gas as well, okay? So you can see here the contrast air level. Can you see it?
Yeah.
Excellent. Okay, so there is, you need to knee-jerk in these cases. Oh my God, this is a case of ischemic bowel. I can see extensive pneumatosis. I can see also free air. I can see all of this you have to mention. I can see that there are venous gas as well. So this patient is an emergency case. He has to be referred for laparotomy. And actually, when this patient was referred for laparotomy, he had a very huge part of the bowel removed because it was already gangrenous. One more thing I want to add here, remember, whenever you find portovenous gas in an adult patient, this usually carries a very bad prognosis, okay? Because 90% of these cases, they will usually not make it, which is the other way around in the pediatric age. Whenever you see portovenous gas, it's not that devastating, and it doesn't usually give you a hint about the prognosis of the patient, okay? So in adults, it's a very bad finding. In pediatric age, it's usually not that significant, okay? Even though the resolution of the portal venous gas in the pediatric age doesn't even show that this patient is getting well. It doesn't go congruent with it, okay?
Yeah,
So
yeah, I could see atherosclerotic changes, but I was struggling to find it if it is axillary trunk or SMA territory. But okay,
Yes.
yeah. And one thing, Dr. Maha, you asked me about the percentage. What is it correctly?
Yes, in the other case, it's 50%, okay? So 50% of
Okay.
cases who present with deep venous sinus thrombosis, usually they will have an associated venous hemorrhagic infarct, okay?
Okay, okay, thank you.
Thank you so much. Thank you. I think overall did very well. Usually they do ask for the, if you would like to know your mark, I think in all the cases you would get a very good 6 or 6.5, okay?
Thank you.
Good luck, all the best.
Thank you.
You're welcome. Okay, we'll move on to the next candidate, I think.
Yes, Dr. Anamika, can you unmute yourself,
Yeah.
please?
Yeah,
Let me check that. Okay. I will just open the list just a second. Okay. Is it visible?
yes.
Okay, great. I'm sorry, I didn't catch the name, doctor.
Anamika, it's Anam.
Okay, how are you? Okay, this is your first case. Let me
Okay.
remember the history. It's okay. So this patient presented with trauma to the shoulder. You can.
Okay. Yeah. So I have been presented with the frontal radiograph of the left shoulder. I can see there is a fracture involving the surgical neck of the humerus on the left side. And apart from that, there's a expansile osteolytic lesion is seen along the greater tubercle of the humeral head and the involving humeral head also,
Mhm.
which
Can you
is
point out?
which is showing also few cortical breaks along with the outer cortex of the expansile lesion, apart from the fracture with the neck and the head. So it looks like a pathological fracture to me. There are no associated fracture, the clavicles, glenoid, and the ribs. No evidence of pneumothorax. No evidence of the any hemothorax in this case, and the visualized shoulder fill. And there's associated mild soft tissue swelling is noted in the left shoulder.
Can you
So
show the lytic lesion you were talking about?
it's
You have the remote control. Just click on the image and.
okay. Can you see now? Is it here?
I think this is projectional. It's because of the, the humeral
Okay.
head that's slightly displaced. And there is also overlap at the region of the neck, so you feel it's a little bit more dense.
Okay.
What do you think? What do you think about the rest of the radiograph?
I can see all the ribs, they are normal. The visualized lung parenchyma is normal. Glenoid appears normal to me. However, the alignment of the glenohumeral joint is not that bad because of the fracture of the neck. And can I see the other view?
Yes, sure. Just click on the first one. Yes. So
Yes,
anything?
there is a reduced subacromial space and the slight upward migration of the fracture fragments. So
Okay, just
reduce.
ignore the bones. Ignore the bones. Other than the fracture, there's nothing else. What about the lung?
I can see few hyperdensities along the left hilum and prominent bronchovascular marking, but since it's a bone projection X-ray, the lung commenting on the lung is difficult for me.
Okay, so what would you know?
But there's a nodule is seen in the left upper zone here.
Okay, so this is the one I wanted to pick up.
Oh, I'm sorry.
Always
Yeah.
remember Dr. John Curtis whenever he says it's your shoulder
Yeah.
radiograph, but you're looking for the lung cancer. Okay, so
Yeah.
just remember this, please. Don't forget it. Okay, so this is a
Okay.
very good catch. So they moved the patient later to go for a CT.
Okay.
I'll just take the mouse for a second. Okay, thank you. Yes, you can scroll through the images and tell us what you think.
Okay. I can't scroll actually.
Really? You have
Yeah.
to. Can you
I'll try with the keypad, but it's not happening.
It's not, so I'll just do it for you. Okay. Okay, just let go of the mouse for a second. Yes, please.
Okay.
I will scroll it for you. I think this is, oh, this is not,
Yeah, this is the preliminary finding.
it's okay.
So here I can see there is a relatively ill-defined multilobulated lesion in the left anterior segment of the left upper lobe, which is showing fine speculation in its margin, in its surrounding, and there's a multilobulation along its margin. And it's on this HRCT film, it's appear homogeneous in that, no venous cavitation in it, and its subpleural location, which is showing few pleural tags along with that. And apart from that, there are multiple paraseptal and central minimal trace central lobular emphysematous changes in the lung. So it looks like malignant solitary pulmonary nodule to me.
It's malignant. Okay, you it looks like it's malignant. It has a spiky outline, right?
Yeah, it's malignant.
The paraseptal emphysema. Just tell me, what do you think? So just wrap it up.
Yes, it's a smoking related, which increases the chances of malignancy in the patient, lung malignancy. So I'll go further with the I'll refer this patient to the lung cancer unit for the further discussion and the management of the lung MDT. Apart from that, I'll arrange for the staging CT chest abdomen and for the CT guided biopsy for this patient, so that earliest possible management can be done.
Okay, great. So when they discussed it at the MDT, they also suggested that they would do a bone scan for this patient, nuclear medicine. So this is part of it. What do you think?
Okay. So here I can see there's a normal physiological uptake in the myocardium and the brain and excretion in the bladder. Apart from that, I can see the nodule has taken the uptake, and one lymph node in the left hilar region is also appears positive, and the fracture site shows just increased vascularity around it.
Yes, because
and
okay.
Yeah, so, and another local area of increased uptake is seen in the proximal aspect of the femoral shaft. I'm not sure about here since I cannot see the bone, but it looks like here it also increase in the left upper proximal femur or the lesser trochanter.
It's fine. This is way what I wanted you to see. Excellent. So let's move into to the next case. This patient presented with hip pain. He is a 10-year-old child who's presenting with hip pain. Just give it a try if you're able to scroll. If you're not, I will scroll for you. Yes, it's.
Yeah, yes.
Okay.
So here I've been provided the MR T1 weighted MR sequence of pelvis. I can see there is a hypointense signal and the reduced volume of the right femoral proximal epiphysis with the slight hypointense signal in the acetabular roof. I don't see any cortical discontinuity although in this. I would like to confirm my finding on the T2 weighted image. Can I have it?
T2 and stir, yes, please.
Yes. So here I can see there is increased hyperintense signal along the proximal femoral epiphysis and the right acetabular and surrounding joint lining
So what do you
on the
think?
right side. It
What do you
looks like yeah,
think?
it's looks like since it's involving both the joint aspects, looks like infective to me.
And the joint?
And the joint is also showing effusion in it, so more goes in the favor of septic arthritis. But there's no evidence of the cortical articular surface erosions on this film, and I would like to confirm this if with the contrast, with the either the contrast or the ultrasound guided aspiration from the hip joint.
So this is your next step, right?
Yes.
Okay, so you move on to the ultrasound. So your final diagnosis?
It's septic arthritis involving the right hip joint, and which is for that I'll urgently convey my finding to referring physician and refer this patient to orthopedic unit for the earliest possible aspiration and start the antibiotic meanwhile.
Okay, so what's the usual mode of spread in septic arthritis in children?
It's hematogenous.
Okay.
And they crosses the faces, so it's more dangerous in the babies. And while if the baby is some immunocompromised, like sickle cell, the salmonella is the common etiological factor, which is more dangerous because it's caused more destructions and the
so would
patient,
you advise for further workup?
yes, yeah, I would like to find the source of the infection in the body. So we'll recommend the
look at the
look at the lung and the
okay,
abdomen,
and the heart, right?
Yeah, and the heart septic emboli, yes.
Yes. Okay. So actually this patient didn't go for an echo because he was known to have a chest infection previously in the past few weeks. So the clinician, he just assumed that probably this is a case of septic arthritis, which was secondary to a previous chest infection. Okay. But you really have to go on to the next case, to the next step, which is I'm trying to look at the cause. And if it's not seen on this film, which is obvious, I have to look for other causes. Okay, you have to tell them, I will advise the clinician to look for a cause or a source of this septic arthritis. Okay, let's move on to the next case. Okay, yes, so that's the yes, it's just loading.
So,
this patient is a 60-year-old patient who is comatose and he's immunocompromised.
Okay, so I've been provided the NCCT images of the brain, where I can see there's ill-defined periventricular lesion in the periventricular lesion, the surrounding white matter edema in the right occipital horn, along the right occipital horn and the right lateral ventricle. And as I can see, it's looks like the ventricle has fluid level in it, or just the right ventricle, lateral ventricle shows the homogeneous densities in that, and there's a effacement of the surrounding CSF spaces and subtle. Also, it's extending along the occipital horn down with the prominence of the contralateral ventricle. So,
you can take a look at the coronal if you would like. Maybe it would clarify things a little bit.
yeah, here's intraventricular lesion involving the right ventricle and the temporal and occipital horn predominantly, with the surrounding white matter edema.
Mhm.
And
So what do you think of the edema? What type is it?
it's a vasogenic edema,
Okay.
not a cytotoxic, which generally is seen in the cases of that the vascular occlusion or ischemic changes are there. But it looks like because of this pathology, a mass effect.
Mm.
has-
Okay.
And
So
here I can see there's subtle hyperdensity along the medial aspect of the ependymal surface of the occipital horn here.
yes. So what could this be? And what would you advise to do next?
So since patient had a history of patient is old and the history of immunocompromised status.
Mhm.
So since it's in a periventricular location, there could be possibility of a lymphoma or toxoplasmoma.
Does it really enter into the ventricle?
No,
Open
or
into
in the intraventricular choroid plexus carcinoma could also be seen, which has hemorrhage and the calcification, but it's very expansile and
Can you see any
filling.
hemorrhagic density?
Yes, I
Very
can see
slight
the
density, but is it hemorrhage?
um
Does it
not
amount
really.
to the Hounsfield units?
No,
of-
it doesn't exactly look. If it's in being hemorrhage, it should have been dependent in location. It looks a
Mhm.
little bit
Mhm.
so could be a calcification or early calcification or a
Okay.
mass
next?
I mean,
What would you do next for this patient?
I would like to have another supplementary study like MRI, if available, in the institute, or
Here for MR.
yeah.
Are you able to scroll?
Actually,
Oops.
it has the screen got shortened, like the
Let go
view
of the
is
mouse for a second.
yeah.
Just- I think, yes. Okay, if you would like me to scroll for you, it's fine. Okay. So these are the T2 weighted images of the same patient.
Okay.
I'll just,
Okay, so here I can see there is a hypointensity along the ependymal surface of the right lateral ventricle with the surrounding vasogenic
this is
edema. And this hypointensity in the T2 is enhancing avidly on the contrast images, and the ventricle is showing bubbly or multicystic peripherally enhancing lesion within
okay.
within the right ventricle with ependymal surface enhancement.
Yes.
So possibility of a
What's the next sequence that would be, you know, like would just finish the case? That you need to see. So what are you thinking of? What's your differential at the moment?
I'm thinking of either a choroid plexus carcinoma or subependymoma or infective etiology.
Yes. What
Since
type?
he was a very like atypical infection like tubercular or CMV or toxic.
Why would it be atypical? Why wouldn't it be typical?
Because he is immunocompromised. So those infections are much common in these patients.
So is an immunocompromised, remember, if a patient has HIV, for example,
Okay.
and you see in the lung the features that are suggestive of, for example, lymphoma, okay? You have to first exclude infection by bacterial infection because this is the most common. And then you go to the less common, which are like OC and the PCP and the stuff like that. So still they can have the typical infections. There's nothing wrong about it. So just take a look at the diffusion and tell me what you think.
Okay, so there is a diffusion and ADC.
Yes.
Uh,
What do you think?
I think in the it's not restricting in the middle where it was.
What are the areas that are showing low signal on ADC and higher signal on the
It's the intraventricular lesion with the basically subependymal surface is showing the restriction and some intraventricular contents.
Okay, so what's your final diagnosis and how would you manage it?
It's infective primarily, considering the ventriculitis and the there is a surrounding edema. So I'll recommend the I'll convey my finding to referring physician and recommend the neurology referral to this patient, and also
So you will just refer the patient to neurology, right? And just mention there is an effective process.
and yeah, because there's a features of ventriculitis and this hydrocephalus, they need urgent management in this patient.
Yes. Okay.
So either VP shunting or
okay, they just manage it the way they see, just to alleviate the obstruction, you mean, right?
Yeah.
Okay, great. Let's move on to the next case. I don't know why this one, I left the history, but so the patient is presenting to the emergency department within 24 hours of vomiting and abdominal pain, and she's a 65-year-old female. Okay.
Okay.
See if you can scroll.
Yeah.
Yes, great.
So I have been provided with contrast enhanced CT abdomen axial images. Here I'm going caudal to cranial. I can see a few prominent bowel loops and a mild central, mild intrahepatic biliary radical dilatation, and the CVD up to the periampullary location with the bulging papilla in the duodenum here. And pancreas looks normal. Appendix normal, so non-inflammatory.
Just speak up whenever you're, scrolling to the image. This is very important in the exam. Just tell that I'm looking now at the right iliac fossa. I can see that the appendix is normal.
Here in the terminal iliac, distal iliac segment, I can see there is some submucosal round structure in it with a calcification in it.
Why don't you take a look at the coronal images as well?
So here's a gallbladder. Gallbladder showing the peripherally calcified calculus in it, and there's a dilated small bowel loops, and distal iliac loop is showing us around peripherally calcified probably structure in it. So it could be because of the gallstone ileus, where the gallstone has passed into the small bowel and caused the obstruction. So for this case, I will convey my finding to the referring physician urgently and refer this patient to surgical unit for the earliest laparotomy.
Okay, so you're happy with it? Okay, so I'll just,
and apart from that, I can see few of the bowel loops are not enhancing well,
Mhm.
and
Forget about the enhancements, it's enhancing well. So let me just take the mouse for a second, just to move on
Yes.
to the next case, okay? So your next case is, let me tell you the history in a shorter way. It's just a child with an abdominal trauma.
okay.
Blunt abdominal trauma.
Okay, so I've been provided the contrast enhanced CT abdomen images of a child who presented with a blunt abdominal trauma.
Mhm.
And here I can see I'm going from cranial to caudal. I can see bilateral pleural effusion, the atelectatic changes. Rice tube is in situ in the stomach, and I can see liver is normal, kidneys are normal, pancreas. I cannot. Pancreas. There's a
Stop.
defect is seen in the region of the pancreatic
Yes. Okay.
neck
Great.
and the body here.
Okay.
So
let's
it's
wrap up this so fast. What would you do next for this patient?
in such cases, since pancreatic duct injuries are common, that crosses more than 50% of the parenchyma. So they need a repair of that ductal leak. And if it's less than 50% transaction, then they can be managed conservative.
Okay, great. So you're concerned about the pancreatic duct, right? So
Yes,
what's
yes.
the investigation that you would do next, just to rule out that there is or not pancreatic duct?
I'll get it done MRCP or ERCP. But
Okay.
MRCP will be preferred because it will be associated with less of the contrast leak.
Okay, thank you so much. I think you did really well. Apart from the brain case, which you struggled a little in, it's fine, no problem at all. In this case, I'll just take the remote control if you don't mind.
Sure.
In this case, you caught it really good, and this is a transection or a part which is an injury. Remember, when a child comes with an abdominal trauma and you have the CT of the child, then first thing look at is the pancreas. I'm concerned. The duodenum and the pancreas. Okay, if there is no free air, then just look at the pancreas right away. But you'd really miss in your reporting or in your Viva here that the pertinent negatives. I cannot see, there is no pneumoperitoneum. Please concentrate on this part, because it's really important. The pertinent negatives, they show that you understand and that you're so safe. You're looking for further complications. Okay, so remember, in any case, you're looking for number one, the cause. Number two, you're looking for complications. Number three, you're looking for any concomitant unrelated findings. So it's the 3 C's. Okay, so you're looking for cause, complication, and concomitant findings that could be just incidental. Okay, so in this case, you picked it very well. Just you have to mention, I'm concerned pancreatic duct could be disrupted. I'm not able to decide on that on the CT, so I will convey the findings urgently to the referring pediatrician, and I will also advise for further MRCP or a retrograde cholangiopancreatography to be able to delineate the pancreatic duct. Okay, at this point they might ask you about, okay, what's the staging of pancreatic trauma, whatever, what do you think that this one is? Okay, I think that this is just a parenchymal laceration with no involvement of the pancreatic duct. Okay, especially that there is, but you cannot be sure, so make sure that you go on for the further investigation. Okay, this is very important, because the surgeon will not approach the case unless he is sure that the duct is disrupted or not. Okay, so let's move on to the I think I missed the case, just a minute. Yes, so in this one, yes, this case you have to wrap really fast. Whenever you see a laminated structure, calcified laminated structure in the distal ileum, first thing, then go up. Okay, I can see that there is a biliary radical dilatation. I can see that the gallbladder, it appears to be okay. There is a calcified stone, as you mentioned. Then you might not always be able to see the defect. Okay, so this is a gallstone ileus. Okay, whenever you see a gallstone ileus, okay, then I will urgently convey the findings. In such cases, when the stones are really big, they usually go for elective cholecystectomy. They remove the gallbladder, even if the gallbladder is not, you can't see a definitive perforation at the CT, they just remove the gallbladder because that's a huge stone that has entered into the bowel, okay? So this is one of the knee jerks, as they say, whenever you see it, okay, that's a gallstone, Ali, okay? So it's one of the favorites, even though it's a very rare cause of small bowel obstruction. Okay, let's move on to this case. First of all, whenever you find a CT brain case, please, 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 if there is hydrocephalus, you have to say it first. Okay, I can see that there is ventricular dilatation. I can see that there is a hypodensity around the ventricles. I'm concerned that this is an acute active hydrocephalus. So this patient, I have to convey the finding to the neurosurgeon because the patient has to alleviate this hydrocephalus. This is first thing. And then continue the rest of the findings. Okay, please don't forget that.
Yes.
You need to convey the point that you are safe. You said, I will alleviate the hydrocephalus, the last sentence after describing the study. No. First things first, just go for the emergency finding and then alleviate it and then move on to the rest of the findings, okay? So in this case, you can see that there is evidence of finger-like vasogenic edema, which is likely part of an inflammatory process, as you said, and there is hyperdensity, which is lining the ventricle. Also, you can see that there is a density, homogeneous density, which is within the ventricular body, okay? So this patient is probably having an infective etiology or an inflammatory etiology because he's also immunocompromised, okay? So let's move on to what will you do next? I do an MRI or I'll do a contrast study if the patient, you know, the templates that we memorize. If the patient is still in the department, I would give contrast and do a CT post-contrast. If not, then I would preferably go for an MRI because it would help me delineate. And then you have to, you're thinking about infection, then you have to look at the diffusion and the ADC. If you look at the diffusion, you can see that all the content of the ventricle appears to be restricted, okay? And then you say that I will confirm on the ADC, yes, it appears to be showing parts are showing low signal, which are high signal on diffusion. This is true restriction. So I move on to the post-contrast and I can see that there is ependymal lining within the ventricle. This means that there is evidence of ventriculitis. I can see some areas of leptomeningeal enhancement as well. And then there is, just a moment, yes, here, there is a cavity over here. Can you see it? And it's having all this vasogenic edema and as it has opened into the ventricle. This is an abnormal passage between this structure and the ventricle, right? And then when you move on to the flare or when you move on to the T2, you can see that there is transependymal seepage, and this gives you another hint. Oh my God, this is acute hydrocephalus. I have to alleviate that. So this patient, you would say this is a neurosurgical emergency. This is an abscess that has ruptured into the ventricles, causing secondary ventriculitis, as well as hydrocephalus. So this patient has to be referred emergently to the neurosurgeons, okay? This was this case, and then I think, yes, this case also, just always concentrate in the Viva on saying the buzzwords, as they say. So you said the buzzword in the middle of your description. You said that there is, yes, there is affection on both sides of the joints. Yes, absolutely correct. I kept telling you, what about the joint space? You have to tell me that the joint space appears to be narrowed, especially along the superior aspect. There's also fusion, as you said, and this is a child. So it's, what is it? It's a septic arthritis of the hip joint. And then what would you do next? I would just go for an ultrasound, as simple as an ultrasound, and aspirate this fluid and go for culture and sensitivity just to give the child the proper antibiotic, because show the concern, show that you're concerned and tell them that this might lead to a permanent disability, might destroy the joint in 48 hours, okay? So I have to go for an aspirate and then under coverage of antibiotics, and this is a radiological emergency, okay? So this was septic arthritis of the hip. And then this one you caught very nicely. I was gonna be really sad if you didn't catch the nodule, because remember that Dr. Curtis, you know, he gives us this example each and every session. And you get caught up by the fracture and and I'm looking at the joints and stuff like that, and you just forget the lung. Okay, so just don't forget the lung. And never say things like it's probably and it's mostly and I think.
Okay.
No, just skip these. Just say there is a fracture, there is a nodule, and this nodule is having a speculated border, and this is a malignancy until proved otherwise. Okay,
Okay.
that's it. Thank you so much.
Thank you. Thank you so much, Dr. Maha.
You're welcome. Okay, I move on to the next.
Dr. Yojit, please
Hi.
can you unmute yourself? Yeah, okay,
Yeah.
perfect.
Okay, I think the screen is visible.
Yeah.
Okay, great. I didn't catch the name again. Doctor?
Hi, my name is Dr. Yojit. Hello.
Dr. Yujit, yes, hello. This is your first case. This is an 85-year-old male patient who's been in the ICU for an extensive pneumonia. What do you think?
This is a frontal radiograph of chest, which shows multiple lines. I can see there is a nasogastric tube, which is with its tip in situ. I can see there are multiple radiolucencies along the neck in the soft tissue, and although there is no evidence of any pneumothorax or pneumomediastinum in the X-ray, I am looking for I can see there is some radio opacity in the retrocardiac region, and
Okay, what do you think about? You mentioned that there is a nasogastric tube. What do you think? Is it going the right way?
I can say there is some coiled tube in the upper part of the neck region, but I don't know. I think this one looks like a nasogastric tube, and this
Where's the tip of the tube?
it's below the diaphragm, so it looks like in situ.
What about the
And,
course?
The course is it has a tortuous course, and it is more on the left paravertebral side. So
Okay,
so
so
it's-
summarize the radiograph.
so there is evidence of altered course of a nasogastric tube with radiolucencies in the soft tissue of the neck region. So I think that could be because of a pneumomediastinum, although I don't see any evidence of pneumomediastinum. There is, although I don't see any radiolucency or air around the.
What are the lucencies in the neck? What do you think they are?
That could be from the. It can be subcutaneous emphysema, secondary to pneumothorax or pneumomediastinum.
Okay, so what do you do next? Are you concerned?
Yeah, I'm concerned. So I would like to do the CT chest to look for any evidence of pneumomediastinum or pneumothorax.
Okay.
And
This is your.
so as
I'll just give you the remote
as
control.
yeah,
Yes, please. All yours.
thank you. Yeah, thank you. So yeah, so I have been provided with contrast enhanced CT scan of neck and chest. As I'm scrolling down, I can see there is subcutaneous emphysema along the soft tissue of the neck on the left lateral aspect. As I'm scrolling down, I can see there are multiple air foci seen along the anterior can I load the chest images also?
Sure.
Yeah. So I'm scrolling from I'm scrolling from cranial to caudal region. I can see there are multiple radiolucent area along the esophagus, and there is evidence of a right pleural effusion. Sorry, left pleural effusion, and the
Where's
I would
the
like to. The nasogastric tube is going into the. I can see it's going into the.
Is it in the esophagus?
Yeah, it's going into the left lower lobe. It's in the esophagus, but it's going into the left lower lobe. So it looks like there is some kind of a rupture. There is a discontinuity in the lower esophagus with the malposition of the esophagus, nasogastric tube into the bronchi of left lower lobe. So it can be a fistulous communication between the esophagus and the bronchi.
Okay, so summarize the case and how would you manage it?
It looks like a esophageal rupture because of with the fistulous communication between the esophagus and bronchus. There is evidence of a pneumomediastinum and left pleural effusion. So, so I would refer it looks like a surgical emergency. So I would refer this to the surgeon for further management.
Okay, so it doesn't look like a surgical emergency. It is a surgical emergency.
Yes.
Fine. I'll just take the mouse for a second and let's move on to the next case. Okay, so this patient is an 80-year-old male and he's presenting with a swollen limb. It's just loading, give it a second. Okay, so the first stack has loaded. You can scroll through.
So I'm scrolling through axial sections of arterial phase of both lower limb. As I'm scrolling down, I can see that both common femoral arteries are normal. The profunda femoris is normal. SFA bilaterally appears normal. Popliteal arteries. So as I'm scrolling down, I can see there is non-ossification of the right popliteal artery with with aneurysmal dilatation and complete non-ossification. And so there is the common peroneal trunk is also non-ossified. Bilateral, the right anterior tibial and posterior tibial arteries are also non-ossified. So to summarize, it looks like acute thrombosis of right popliteal artery, right anterior tibial and right posterior tibial artery. And
go back to the popliteal fossa.
Yeah, with aneurysm. Yeah.
Okay.
Yeah, with the aneurysmal dilatation, it looks like the aneurysmal dilatation. So,
what's the first thing you would do if you would have a popliteal artery aneurysm? What's the next thing you would do and look at?
I would like to take a look at heart to look for any source of any emboli, to look for septic emboli.
Okay, so what would you do next for this patient?
Echocardiography, and I would refer, since it's a surgical emergency, I would refer this patient to CVTS surgeon for embolectomy.
Okay.
And I would arrange echo and I would ask for history of any drug abuse
Okay.
And I would like to take a look at heart with echo to look for any source of any emboli.
Would you like to take a look at the aorta as well?
Yes, yeah, to look for any atherosclerotic changes in the aorta and to look for any source of emboli. Yes.
Okay, let's move on to the next case. I'll just take hold of the mouse for a second. Okay, so this is a 19-year-old female who's presenting with pelvic pain.
Yeah,
Are you
so-
able to scroll?
Yeah. Yeah. So 19-year-old young female presenting with a pelvic pain. I am looking through the axial T2 weighted images of a pelvis. As I can see, the right ovary looks normal. The uterus looks normal. There is no focal lesion. I can say there is mild free fluid in the pouch of Douglas, and the left ovary, it appears bulky and it has heterogeneous signal intensity with increased T2 hyperintense signal, and I would take a look at T1 weighted images to look for, it appears isointense on T1. And on DWA weighted images, there is a increased signal, which I would like to confirm with ADC map to look for diffusion restriction. And since the ovary appears bulky and it is not seen in the left adnexal fossa, it is seen posterior to the uterus. I am considering it to, there is a possibility of a ovarian torsion. So I would take a look at the contrast study to look for the enhancement. So I can say there is a cyst in the ovary, and it has, sorry.
No problem. That's the coronal T2. You wanted the contrast?
Yeah, I just, yeah.
Okay.
So I think it is, there is a complex cyst in the left ovary, which looks like a hemorrhagic cyst, and it has led to the torsion of the ovary. And
What would
I
you
would
do?
I would confirm my findings with the Doppler study.
Would it really
and-
matter? What would you see in a Doppler?
I would like to take a look for arterial and venous flow, or so what kind of a compromise is
Okay,
there.
so is it always
Just to
ruled that
confirm,
the ovarian torsion would lead to vascular compromise? Is it is it a constant finding?
sorry, I didn't get you. Hello?
Okay, so you were mentioning that you would go for a Doppler, right?
Yes.
How would the Doppler help you out in this case?
To look for any arterial or venous compromise on the Doppler study
Okay.
for torsion.
Okay.
And I would confirm my finding of a torsion on the Doppler study.
So would you rather go for an ultrasound and Doppler, or do you really think that this study is enough and that you've diagnosed a case and it's an emergency, so you have to convey to the surgeon, right?
Yeah, so it's an emergency, and I would like to refer this patient to OBGY for emergency laparoscopy and SOS detorsion.
Okay, great. Let's move on. This is your next case. Just give it a second to load. It's a 50-year-old male patient who's presenting with abdominal pain. Yes, it's loaded. You can scroll now. 50-year-old with abdominal pain.
Yes. I've been provided with axial sections of contrastinous axial sections of abdomen and pelvis of a 50-year-old male with abdominal pain. As I'm going through upper abdomen sections, I can see the liver appears normal, the gallbladder appears normal, I can see the nasogastric tube is in situ, spleen appears normal, and there is mild free fluid seen in right subhepatic space. Pancreas look normal, and I can see there is mild twisting of a. I'm looking at the relation of a SMA and SMV, and I think there is some twisting of SMA and SMV. I can see SMV is on the left.
Can you
in
point it
relation to
out
the,
for us, please?
yes, yes.
Okay.
So as I can see here, there is the SMV is seen to the left of the SMA, and I'm looking for a DJ flexure and its position on. I'm looking for the position of a bowel.
Okay, let me stop you here.
Yeah.
Okay, this is a major mistake that we all do. Just continue the rest of the study till the end and then
Okay.
start describing, okay?
Okay. 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 I'm scrolling down. I'm looking at small bowel, large. So I can see there are multiple dilated bowel loops with air fluid level in the pelvic region, and I'm looking at the hernial orifices. There is no evidence of any hernial orifices. I'm looking for the transition point, since I can say there is collapsed small bowel loop also. So it looks like a mechanical obstruction. So I'm looking for a transition point. I'm looking for any evidence of previous surgery. So
So what's the type of
there
the
is,
obstruction?
it looks like a closed loop obstruction, because just and I'm looking.
Anything else you're concerned about apart from the obstruction?
There is. I'm looking for evidence of any pneumoperitoneum, which is not there. I don't see any free gas. I don't. The bowel. There is no evidence of any vascular compromise. The bowel wall is enhancing. There is no evidence of any pneumatosis in the bowel wall. And so it looks like it is a surgical emergency, and I would like to refer this patient for a emergency laparotomy for immediate laparotomy.
Okay. Can we just let go of the mouse for a second? I'll just
Yes.
next case. Okay. So this patient has had a trauma, and now his hand is put in the cast. We just they needed a rereading for it because they weren't really convinced about the first report that was presented. You can take a look at all the images, the frontal and lateral.
Okay. I've been I've been provided with X-ray of a right wrist with frontal and lateral projection and oblique projection. As I can see, there is evidence of a fracture seen through the base of first metacarpal, which is shown with the extension of fracture line to the articular surface. So it's an intra-articular fracture of base of the first metacarpal. On lateral view of the wrist, I can see there is Scaphoid unit dislocation. And so
Usually diagnose that on the lateral radiograph.
yeah, I can diagnose it on AP also. There is the distance between the scaphoid and unit, it looks normal on the AP, but on lateral, I think there is a the saucering cup deformity. I can see there's a saucering, there's a disruption of
Which bone you're pointing to at this moment? Yes, this one. Yes, here.
this one here. This
Yeah.
looks like
Uh-huh.
this is a lunate bone.
Excellent. The one above it? Yes.
This one,
Yes.
it's a capitated.
Okay, so can you tell us what's the problem here?
So there is a perilunate dislocation. There is a ventral movement of
Okay,
lunate bone in relation to the capitate. So it looks like a perilunate dislocation.
okay, great. So the rest of the radiographs, anything else you would like to add?
So this indicates there is a disruption of a scapholunate ligament. So
Any other findings?
I can say there's a fracture of pisiform also. So I think.
So you're concerned about the carpal bones, and you think that there is a perilunate dislocation, right?
Yes, yes.
What about the scaphoid? Are there other fractures that you can see? What would you do next for this patient? Would you let them go and then tell them, okay, the cast is fine and it's well, or would you like to do anything extra?
I would like to go for scaphoid view since I'm not able to see the scaphoid.
It's a little bit hard to go for a scaphoid view in this position, you know, he's already in a cast and it's a little bit difficult. So we just went on for a CT.
Okay.
Tell us what you think in the CT. And does it really confirm your findings on the plain radiograph?
So on plain CT, as I'm scrolling through the coronal images, I can see both the lower end of radius and appears normal. And regarding I don't see there's a fracture of base of first metacarpal. So, and the scaphoid looks normal. No, there's a fracture through the scaphoid.
Yes.
Yes, okay. And there is a perilunate dislocation also, and there is a communicated fracture seen through tricuteral bone also.
Yes. Okay. So can you summarize the findings? Tell us what to do next.
This is. I would refer this patient since it's there are multiple carpal bone fractures. I would refer this patient to the fracture clinic and
yes.
Yeah, it looks like it is a case of a fracture, scaphoid fracture. So since there's a scaphoid fracture, there's a risk of AVN.
Yes.
So scaphoid may need intervention, surgical intervention for the prevention of
Yes, for further fixation, right?
For the fixation, yes.
Okay, so let's start the feedback because we're a bit late. For this case, you do have what's called a transcaphoid perilunate dislocation, right? Remember, whenever you do, because this is a common even in the daily practice, that you do diagnose a perilunate dislocation and then you don't check for the scaphoid or any other fractures, okay? Then this is what happened with this patient. They just found the perilunate dislocation. They diagnosed the scaphoid fracture, and then they couldn't see that there is a dislocation as well, okay? And this is something that could be disabling on the long term. So this patient went later on for fixation of the scaphoid fracture, as you mentioned, that there is high risk of a vascular necrosis, and also for a fixation of the triquetral fracture, which was very obvious on the plane radiograph. If I would just show it to you retrogradely, you can see maybe because of the cost, it's a little bit resolution is not that nice, but it's here, okay? On this image, it's very obvious that you can see that there is a perilunate dislocation. You can see that the capitate is in alignment with the distal radius, but the lunate is totally out of the way, okay? There's one more thing on the CT. They also mentioned that there was a very tiny non-displaced fracture of the distal radius. So just make sure that you don't have very long poses, okay? Just try to know the sequence of the cases. In most of the cases, it's really the sequence is known. If you see a case of perilunate dislocation, then you're definitely looking for a scaphoid fracture, any other fracture on the way, any other dislocation, but you need to rule out the scaphoid fracture and the scapholunate dissociation, okay? So this was this case. And of course, this is an emergency issue, as you mentioned. For this case, it's fine, but remember that closed loop obstruction is still a surgical emergency. You can see here, you have to tell me two buzzwords in this case. You have to tell me that I can see that there is the double beak sign, okay, which is here. You can see the double beaking. And then you have to tell me that there is swirling within the mesentery. I can see that there's swirling, and this is diagnostic of a closed loop obstruction, whatever the cause. You can't always find the cause for small bowel obstruction, do you? And then in this case, there was something of a slight satisfactory of search. And this is one thing that we always fall into, especially in the exam and even in the day work. If you can see here, there's a small blind-ended tube. Can you see it? That has disappeared. If you follow it, you would find that this is the appendix. So for this patient, if we follow it even on the coronal here, can you see this one? It's a blind ending tube, okay? So this turned out to be in the end as a mucocele of the appendix, and this patient, instead of going into laparotomy for only alleviation of the intestinal obstruction, he did a total right hemicolectomy, because when they took the pathology from the appendix, it turned out to be a low-grade mucinous cancer, okay? So in such cases, do not fall into the satisfactory search. I know it might be a bit difficult, but it's important not to miss any findings, because you can see in this case, the patient would have gone only for the intestinal obstruction management, and then miss the mucocele of the appendix, and then need to go again for surgery, okay? So in this case, the management was actually a right hemicolectomy for this appendicular mucocele. In this patient, very well, very nicely said. Remember, you can have a hemorrhagic cyst. It can be also, I'm sorry, this is, sorry, I missed the case. The one for the ovarian torsion. Yes, my question was, would the patient benefit from the Doppler? Remember, for ovarian torsion, it doesn't always affect the vascularity of the ovary, because the ovary has a dual vascularity through the ovarian and the uterine vessels. So it's not the same way as the testicles. In the testicles, if there is torsion, it's definitely going to affect the vessels, okay? But in ovarian torsion, usually MRI is definitive for diagnosis. And always remember that a very young female that has a bulky ovary and abdominal pain is definitely an ovarian torsion until proved otherwise, okay? Plus the presence of the fluid surrounding it and the bulky ovary, the presence of the corpus luteum cyst. In this case, this was the cause of the torsion, okay? So just remember, these are classical histories whenever they tell you a female with abdominal pain and bulky ovary. So definitely you would want to save the patient time. You don't want to go for a Doppler, whereas the patient can go into surgery and and salvage this ovary, okay? In this case, I was asking you, whenever you find a popliteal artery aneurysm, you have to tell the examiner, okay, I'm looking on the other side, because popliteal artery aneurysms are commonly bilateral, okay? So when you look on the other side, you find that there is also an evolving aneurysm as well, because this is not the normal caliper of the popliteal artery. This is far beyond the normal. And you can also see that there is thickening of the wall, which means that there is mural thrombosis within this aneurysm. And then when I asked you, what would you do next? You have to tell me that I will have to screen the abdominal aorta, because in 50% of the cases who have popliteal artery aneurysms, especially if they are bilateral, they usually have an abdominal aortic aneurysm, okay? So these were the questions and these were the answers. You have to, when you see popliteal artery aneurysm, tell the examiner, I'm looking at the other side because it's usually bilateral. And then I would also screen the abdominal aorta because it could be also an association, okay?
Okay.
Let's move on to the last one. In this case, you did it very well. You actually caught the finding from the very beginning, but then you kept repeating, and then you couldn't take it further. You said that the nasogastric tube is coiled, and this is absolutely correct. And then you can see here that the nasogastric tube, it has a very abnormal course. This is not the course of the esophagus, okay? So in this case, the nasogastric tube, it perforated the esophagus at one point, it went into the submucosal area, and then it re-entered the esophagus once again, and then went into the stomach, okay? So it's very deceiving, because you can see the tip of the tube within the below the left hemidiaphragm, but on the other hand, you can still see that there is surgical emphysema, and this is concerning, right? So in the view that you can see surgical, and if you concentrate a little bit, you can see that there are slight lucencies along the mediastinum and the trachea. So this could also, you would say that I cannot confirm the presence of a new mediastinum, but there must be a new mediastinum, since I can see that there's surgical emphysema at the root of the neck. So I will do a CT scan. So when the patient did the CT scan, they could see that there is actually pneumomediastinum, and there was perforation of the esophagus, and he had to be moved to the laparotomy right away just to repair the ruptured esophagus. Okay.
Okay.
So these were
this was a iatrogenic.
Yes, this was definitely iatrogenic. Yes.
Okay.
So the patient was going
So
through pneumonia, and
the
then
one in the neck. The one in the neck is there are two entities. That means one is the coil tube in the neck. What is this?
It's a single NGT, but it was coiled,
Okay.
and then it punctured the esophagus and then came out into the mediastinum and then repunctured again. It's a very weird case, but but in the end, you see that there is abnormal. You don't have to. What I want you to know is that you should not leave something like that. You're concerned about, even if you say in the exam, I'm concerned about the abnormal course of the nasogastric tube, even though it's projecting below the diaphragm, but what's all this coiled? And I can also see that there is surgical emphysema. I would be concerned if this patient has had any previous intervention lately. Maybe he had a central line in place. Maybe this NGT was inserted in a faulty way. So in this way, they feel that you are a safe radiologist. Maybe someone else would see this radiograph and then see the tip below the diaphragm and then say, okay, it's normal, there's nothing. Okay, just try to be meticulous. You can see that there's an abnormality, just say it right away. And believe me, in the exam, if you do pick an abnormality that is irrelevant, they will right away tell you, no, just ignore that. Okay, they wouldn't want you to go and waste your time. Okay,
thank you so much.
You're welcome. Thanks to you. Okay, let's move to last candidate. Okay, so Dr. Sabahat, are you with me?
Yes, I'm with you, Dr. Maha.
Okay, dear. Let's start. You can see the screen, right?
Yes, I can see the screen.
I'll give you the remote control. Just a second.
I have asked. Okay,
yes,
it's there. Okay, so I have been provided with axial CT brain images, contrast enhanced portovenous phase. I'm first scrolling through the images once. So actually these are CT temporal bone / skull base post contrast. And I can clearly see there is an avidly enhancing lesion centered around the left mastoid bones. and it has a sort of punctate, it is avidly enhancing with punctate areas of enhancement as well. It is eroding in the area, it is eroding the bones, the mastoid bones in the area of jugular foramen. I would like to see the bone windows as well to see the extent of bone destruction. So as I saw in the soft tissues windows, the mastoid area is destroyed, especially in the area of jugular foramen. With the pattern of enhancement, my first differential would be a paraganglioma, the glomus jugulaire in this area. I would immediately discuss the findings with the clinician, ask about the clinical setup, and if required, an MRI further can be done. But my prime differential would remain a glomus jugulaire tumor in this case.
Okay, great. So can you just tell me the extent again through the bone window?
Okay, so in the bone windows, I can see that the mastoid bones on the left side is completely destroyed. So if I compare with the right side, this is the area of the jugular foramen, which I can see is destructed here. So there are what they call pars nervosa and the pars jugulaire areas. So both areas are destructed here. And perhaps some extension into the petrous apex as well, but the main epicenter is the mastoid bone and the pars jugulaire area.
Okay. I'll just move on to the next case. Okay, so this is your next case. This patient had some wrist pain, so he just went for a radiograph of the wrist.
Okay, so I've been provided with multiple views of the left wrist. I'm having a look at the frontal, oblique, and lateral. So the first thing I can see is that there is asymmetry in the size, in the alignment of the radius and ulna. That is, the ulna is there is ulnar negative ulnar variance. There is lateral medial slanting of the radial aspects towards the ulna, so it seems to be closely opposed with a slanting. There is a sort of ulnar tilt as well here. So I believe this is the Madelung deformity, if I remember correctly, which is seen, which has multiple causes, including the post-traumatic. It could be, there is a syndrome which I'm completely forgetting at the moment. I would like to compare it with the previous images if possible. And I would refer the patient to the orthopedics and see whether he could be correlated for any symptoms he's having because of these.
Okay, so what are the definite criteria that you would diagnose with the Madelung deformity?
Yeah, so the main features are negative ulnar variance, the tilting towards the ulnar aspect of the distal radius, both in the longitudinal axis as well as on the transverse axis, and a sort of something getting a triangular shape of the proximal carpal row, that is, it is sinking into the abnormal shape of the distal radioulnar joint.
So is usually negative ulnar variance associated with the Madelung deformity, or is it the other way around? Is it
I think I believe negative ulnar variance is related to the Madelung deformity, yes.
Mm-hmm. Okay, so you think in this case it was a case of trauma previously, or?
It could be post-traumatic, it could be idiopathic, or it could be syndromatic as well, which I can't remember at the moment, the syndrome name.
What's the easiest that you would do next?
Yeah, the CT scan in this patient.
Wouldn't you like to compare with any previous?
Yes. If there is any previous or of the right hand or any previous X-ray of the left hand as well to compare.
Yes. So the most important thing in any Madelung deformity, I mean, check the other hand. Just tell them I would need to compare with the other hand, because if this is a case of trauma, then probably it will be unilateral. If it was syndromic, then it's bilateral condition. Okay, even though that you have some syndromes that may have it unilateral, such as Olier's syndrome and stuff like that. Okay, but let's come back to this case later. Let's move on to the next one. Okay, this patient is a 60-year-old male patient who's presenting with acute abdomen.
Okay, so frontal abdominal radiograph of a 60-year-old patient presenting with abdominal pain. The first thing I feel striking is this sort of paucity of the bowel loops in the center of the abdomen as well as in the largely in the left side. In the right side of the abdomen, I can see that there is fecal matter, most likely in the ascending colon, but I'm a bit concerned about the lucency, which is overlying the right side of the abdomen. It does not conform to the expected outline of a bowel loop. But the patient is supine, but still I'm concerned. So I will go either for a decubitus or a CT abdomen in this patient to understand that why this patient has this lucency or sort of air in the right side of the abdomen.
Okay, let me stop you here.
Yeah.
Do you think the abnormality is on the left side or on the right side?
Okay, the abnormality is on the left side of the abdomen. So basically there's a soft tissue abnormality largely on the left side of the abdomen, which has displaced the bowel loops superiorly and to the right side. And the patient would need further evaluation either with the ultrasound abdomen first, or the CT abdomen with contrast would be my preferred modality for a definitive diagnosis in this case.
What's the one and only sign over here that's very concerning?
I can see a sort of lucency here in overlying the right hypochondrium, but I'm not really. Sorry, you can't see the cursor? Sorry, can you see the cursor now?
No, ignore.
Yeah, okay. So when I'm the emergency things which I should be able to see and outline on an abdominal X-ray would be pneumoperitoneum, would be any air around the retroperitoneum, which I can't see, any portal venous or biliary air, which I'm not convinced about in this X-ray. I do have I can see a lucency.
No, it's nothing.
Okay, so I'm not really sure if I can see any anything else other than this large soft tissue mass in this patient.
So what's your differential for that?
Yes, so this differential could be a huge spleen or a huge retroperitoneal lesion which is displacing the bowel loops, or a lesion arising from the pelvis and going up. If it was a female patient, I would be really concerned about a pelvic mass.
Is it continuous with the pelvis? In this case?
Actually, for me, roughly, this seems to be the soft tissue density lesion. And okay, I can see the bowel loops here. No, it's not going into the pelvis.
Okay.
So, yeah.
So just remember the history. It's a 60-year-old male patient who's presenting with acute abdomen. So
because he's presenting with acute abdomen, it can also happen in acute hemorrhage, like a retroperitoneal hematoma. That could be one of the reasons. I do not see any signs of sigmoid or cecal volvulus, which could be again a reason for acute abdomen in an elderly patient, especially the sigmoid volvulus. A mesenteric ischemia of the bowel could be one of the reasons, but I cannot see any finding on the abdominal X-ray in this elderly male patient.
So this means that you're really concerned about the case and you would like to take it further. What would you do next?
A contrast enhanced CT abdomen.
Okay, let me just take them out. And here you go.
Okay, so I've been provided with axial CT abdomen, non-contrast. I'm going to have a quick scroll through the images first. Okay, so while scrolling the images, the first striking finding is aneurysmal dilatation of the aorta with high density retroperitoneal high density, most likely hemorrhage in the retroperitoneal area and anterior to the aorta, which indicates that there is not only aneurysm but also hemorrhage from this area. I can also see this high density in the margins of the aorta, indicating mural hematoma element as well. The amount of hemorrhage is extensive. It has also lifted up displaced the kidney. This is an emergency. I would contact the vascular surgeon and also inject contrast in this patient, which would better delineate the extent of aortic aneurysmal rupture and help the vascular surgeon in its planning. The interventional radiologist can also be, I would also involve the interventional radiologist who might be able to do the stenting and help out the cardiac thoracic surgeon in this case.
Okay, great. Let's move on. This is your next case. I will just give you a rapid history. This is a case of renal failure in a 5-year-old female patient.
Okay, so abdominal radiograph, pelvic radiograph frontal projection, 5-year-old renal failure. The first thing I can see is a coil tube within the pelvis, which is a peritoneal dialysis catheter. I can see diffuse osteopenia in this 5-year-old patient with actual resorption of the femoral head and neck bilaterally, which I believe is the part of renal osteodystrophy, the hyperparathyroidism, which has led to the resorption. There is, secondary to resorption, there is also displacement and upward dislocation of the femoral heads. So basically, this is the sequelae of renal osteodystrophy. I would take the case further and involve the orthopedic and the nephrology in this, because this child would be having difficulty in walking and he's only 5-year-old. So a management plan should be made in place to help him restore his hip joint and his ability to walk.
Okay, what other findings could you see in cases of renal osteodystrophy?
So in renal osteodystrophy, basically we see brown tumors, we see subperiosteal resorption, we would see rugged dorsal spine in the vertebral bodies, and in the hands, there would be subperiosteal, typical locations of the subperiosteal resorption of the radial sides of the second and third fingers. There would be patchy areas of lysis and sclerosis, depending on the stage. That's what I can think of at the moment.
Very well. Okay. So this is your next case. It's a 60-year-old female who's presenting with acute onset of headache.
Okay, so I've been provided with the axial CT brain images of a 60-year-old female patient who has presented with acute headache. I believe these are non-contrast study. So I have scrolled through the images once. Now, as I'm going down, I can see that there are scattered areas of fat density globules in the subarachnoid spaces and in the falx. I feel that when I compare the two sides, I feel that there is high density within the cells.
It's a fact. It's not a feeling. Okay.
Oh, okay.
There's no I feel and I think and I. There's no.
True. So as I scroll down, I can also see that there is high density within the sylvian fissure and the adjacent subarachnoid spaces. I can also see further fat globules interspersed within the parenchyma. I can see a very well-defined fat density lesion with some calcification and some soft tissue elements in the right temporal lobe. So I believe that this patient has dual pathology of ruptured dermoid cyst as well as subarachnoid hemorrhage. The concentration of this hemorrhage is in the region of left MCA. If the patient is still on the table, I would proceed further with contrast enhanced with CT angiography to rule out underlying aneurysm in this patient.
Okay, very well. There's your angiography.
Okay, so this is the conventional digital subtraction angiography in this patient. So I can, this is the left carotid angiogram and I can see, okay, so this seems to be, there is an aneurysm originating from the left M2 segment, left middle cerebral artery. I would convey the finding immediately to the interventional neuroradiologist as well as the neurosurgeon. So there are two things which should be managed in this patient: this aneurysm as well as the ruptured dermoid cyst, which can lead to chemical meningitis. So that's it.
Okay, so what would be the sequela of the chemical meningitis? What would be your pertinent negatives on the CT scan?
Okay, on the CT scan on the brain, I would of course look at the extent of the dispersion of the fat within the intracranial, including the ventricles and the subarachnoid spaces. But I'll also be concerned about the spinal axis, the whole neural axis, because once it's in the CSF circulation, it might circulate down into the spinal canal as well, causing chemical meningitis in spinal cord as well.
Would it go up?
Depending
Imagine a very, examiner who's really comic. It will go up, right? It's fat.
Yeah, it will. Yeah.
Okay.
It will.
So, one more thing, chemical meningitis. What would be the sequela if it's complicated in the brain? You would have to be looking for vasospasm and infarct. Okay, that was the point. Okay.
Right.
So just remember that you mentioned that it's a ruptured dermoid, and I'm concerned about meningitis, and I'm excluding the presence of any hypodensity, which I cannot see in the current study, which means that there is no superadded infarct on this case till now. Okay.
Okay. Okay.
But very nicely described, actually. Let's move you on to the next case.
Okay. So these are, I have been provided with mammography images.
This is
These,
female,
sorry,
60-year-old female who's presenting with a palpable mass.
Okay.
Okay.
Okay. So these are, I'm looking at the CC view, right and left, and the MLO view, right and left. So in the right breast MLO view, I can see that there is a spiculated high density mass nodule in the upper half of the right breast, in close approximation with the pectoral muscles. I cannot see that lesion in the CC view, most likely because it is very posteriorly located and near the chest wall muscles. I do not see any clustered microcalcification within this lesion. There are few faint calcifications within the breast. Sorry.
Are you able to see the microcalcifications, or what would you do to see that?
I would magnify the image to see the microcalcification, but in the sorry.
You have to mention that you're magnifying, or you're gonna take extra views. Okay.
Okay. Okay. However, because of this speculation and its close approximation to the pectoral muscles, I am concerned about the 60-year-old patient. I would inquire if the patient has a previous mammogram, then I would compare, and I would flag this patient as to need triple assessment, and a biopsy is a must. And if this patient turns out to be a cancerous lesion, then it has to have staging CT test and discussion in the breast MDT.
Okay, great. Good job. Your next case.
Okay.
Let me tell you, a 45-year-old male patient who's presenting with abdominal pain.
So I have been provided with the scout images, frontal and lateral, of an adult patient who has presented with acute abdominal pain. I can see that there are dilated bowel loops in the center of the abdomen with valvulae conniventes. I do not see any dilated bowel loop on the periphery. So from the scout, I do not see any bowel loop overlying the expected regions of the hernia, inguinal hernia. So this is a case of small bowel obstruction. I'm concerned, and I would proceed with contrast enhanced CT abdomen in this patient.
Okay, anything else on the scout?
I do not see any free air. I do see degenerative changes. I believe what I see over the sacrum and the hip joint are artifacts. There are air fluid levels in the scout lateral film. Perhaps some atherosclerotic aortic calcification.
Give me the mouse for a second.
Yep.
Let me show you something. What do you think of this bowel loop in particular? This one.
Pneumatosis. There's air in the bowel wall. Yeah.
This was the whole thing about the scout. So always scrutinize the scout, especially if they give it to you first, because definitely it will have something to do with the case.
Yeah, yeah.
This is the rest of the study, which you can.
Okay.
Right.
So I should start with the non-contrast first. Okay. So this is axial CT abdomen, non-contrast. I'm scrolling craniocaudally. As I'm scrolling, I can see that there are linear branching lucencies in the liver, which are extending up to the periphery of the lungs, indicating portal venous air. I can see advanced atherosclerotic vascular calcification noted in the aorta and its major branches. I can see that there are calcifications even in the branches of the renal artery. Okay, I'm looking at there are scattered areas of calcification in the pancreas as well. I look further, I'll evaluate this further in the contrast enhanced, but I'm concerned about these foci of scattered calcification.
What could it be?
It could be the aortic graft repair, it seems.
Where?
Because this one, it has to, sorry.
No, this is just calcification within the onset process. It's going downwards.
Okay.
It had multiple attacks of pancreatitis before.
Okay, and I can see that there is extensive dematosis in the bowel loops, which are dilated. I can see it's going all the way down, and then I can see collapsed ileal bowel loops. So there must be a transition point, which I'll interrogate further in the contrast enhanced CT abdomen. So at the moment I have the arterial phase study. I'm scrolling again craniocaudally. This I can see that the aorta, abdominal aorta, is well opacified. I'm waiting for the celiac axis to emerge. Okay, so this is the celiac axis. It has a sort of beaded appearance because of the vascular calcification, but still good caliber. The superior mesenteric artery is also well opacified. The right renal artery and left renal artery are fine. The inferior mesenteric artery is also well attenuated. I'm wondering, and again, the redemonstration of the dilated bowel loops with collapsed terminal ileal bowel loops. In my routine,
find a cause on the CT, right? So what would you do next in the workup of this patient?
I could not find any arterial cause, but there might be a venous cause, like a thrombus in the SMV. So for that, I would look at the portovenous phase.
Okay, there was nothing. It's not.
Okay. So if it's not the ischemic cause, then there should be a mechanical cause, like a transition point. So here I can see that, these are the dilated bowel loops, but here I can see collapsed bowel loops. So perhaps this is the area, the transition point, and the way it is abrupt, this could be due to adhesions, due to a history of previous surgery, which I would ask the clinician that if this patient has had previous surgery, which can lead to adhesions, and in the long run, it can lead to such acute attacks of bowel obstruction, leading to ischemic changes within the bowel, and hence leading to portal venous air as well, which is a bad prognosis in this patient.
So what do you think of the prognosis of the pneumatosis? Is it good?
The pneumatosis, I would believe with the combination of portal venous air, the prognosis here is not very good. This has to be urgently conveyed to the surgeon, and every possible attempt should be made to salvage the bowel and the patient here in this case, but the prognosis is not good.
Okay, good job. Okay, thank you so much. This was very nice. I enjoyed a lot. I like your way always, Sabahat, I don't need to say.
No, you should. There is still always room to improve,
No, I really like the point is that you're confident. I always feel that you're so sincere about each patient, and this is something that I've learned from you, which I like a lot. You're so meticulous. You look at everything, so that's really good, and keep it up. I wish you best of luck, really, from all my heart. And for this case, you did really well. The patient had a history of atrial fibrillation. I just wanted you to tell me, okay, I'm concerned that there could be a thrombus, which I cannot see. I will check the heart as well. Always remember to check the heart, okay? But well and good, you have to exclude, in any case of pneumatosis and intestinal ischemia, you have to exclude arterial causes, venous causes, as well as sometimes there is no obvious cause, which is called the NOMI, or the non-occlusive mesenteric ischemia. Remember, some patients who are sniffing cocaine, they may also present with ischemia, which you are never able to find a specific pathology resulting regarding the vascular structures. So these are other causes. One more cause other than the arterial, venous, and the NOMI, you can also describe in cases of severe hypotension. So if this patient is having severe cardiac failure and extensive myocardial infarction, so you have to tell me, I'm looking at the inferior vena cava, I'm looking at the adrenal glands for any evidence of hypotension, which wasn't the case here, okay? So these are the different causes that you need to exclude on a case of ischemia where you can't find a real reason, okay?
Okay.
This case was really good. In this case, it was lovely. You did everything in the first slide. I've put this case especially just to show you the normal sequence of mammogram. Whenever the patient is coming with a palpable lump, first thing you have to say, I will refer this patient to a specialized breast clinic for triple assessment, full stop. That's it. Do not, please, do not talk about calcifications. Do not talk about the margin. For such cases, they have to go for triple assessment, because I will show you in this case, it's a very nice example. When this patient went to the specialized breast clinic, because the lesion, as you mentioned, was really peripheral within the region of the axillary tail and it was abutting the pectoralis, they took extended craniocaudal views to be able to visualize it better. And then when they took the extended craniocaudal view, they couldn't still see well, so they just took what's called a count view or a magnification view on the lesion. And these are all very important steps, which you will not do. You will refer the patient to the specialized breast clinic so they can do further these investigations. After doing all that, once the lesion has been characterized that it has some speculated margin and doesn't look nice, and here you can say that the magnified views are not able to see any microcalcifications, so they have to go for the ultrasound. This was the next step. The ultrasound showed that this looks like a malignant lesion with the posterior shadowing and the irregularity, and it appears to be taller than wider, and the stuff that you all know. And then in the end of the ultrasound, they did the biopsy, as you mentioned, and I like the fact that you said biopsy is a must, but still, it's not your choice. I'm sorry, you have to refer the patient later for MDT. What the MDT do, that they take the findings of the mammogram and the triple assessment of the mammography, the magnification views, as well as the ultrasound and the biopsy, and then they check after biopsy if it's a lobular cancer. They tell the patient to go for further MRI investigation because it's a lobular cancer, could be multicentric because some cases may not be detected on mammogram. And then they check for, the most important point is the concordance of the findings within the different stages, okay? That the biopsy is going with the mammo, is going with the ultrasound, is going with the MRI, and then they tell the patient what to do, okay? So I really like the fact that you just, wrapped up the case within the first slide. But just remember that it's the buzzword here is the triple assessment, and that I will recheck again after magnification. This is very important. And you may ask, by the way, the examiner, okay, I would like to magnify because in my usual practice, I would like to see the microcalcifications with magnification. They might tell you at this point, okay, go ahead, or no, don't worry, there is no microcalcification, continue, okay?
Okay.
In this patient, you did very, very well. Wonderful, lovely. The point is that you told me it's a dual pathology, and I can see that there is subarachnoid hemorrhage, and it's centered with the pooling of the blood in the region of the left sylvian, and there is also ruptured dermoid. This was excellent, really great, and asking for the angiography later was very good. This patient, it's a really easy case just to pass by. It's a case of devastating renal osteodystrophy, as you mentioned correctly. This case. Okay, this one. In this case, I was asking you, what is the most important thing that you need to, striking thing that you have to tell me in this case? You have to tell me that I'm not able to see the left psoas shadow.
Yeah.
That's it, full stop. It's a positive psoas sign. And that's
Yeah.
it. Whenever you see a positive psoas sign, then you're thinking about a retroperitoneal problem. And since the patient is old age and is presenting with acute pain, okay, all the differentials you said were really, really good. But you need to exclude an abdominal aortic aneurysm, okay? Especially if it's bleeding, okay?
Yeah.
One more thing, if you're saying that it's a retroperitoneal or it's something that is paravertebral, just show off a little bit and tell them that, okay, I'm looking also at the vertebra. I cannot see any erosions or anything that might suggest that this could be, for example, a psoas abscess or a Pott's disease, no destruction, nothing. Okay, so go on with your differentials in a systematic way and exclude every part. In this case, you will reach the diagnosis right away. For this one, it was, as you saw in the CT, it's an abdominal aortic aneurysm. I wouldn't say that the patient would go for contrast study because the non-contrast is extremely devastating. If you look for here, in these patients, they want to go on for surgery right away just to save the patient, okay? And in this patient as well, you can see that there is hyper-intense appearance of the, this is a non-contrast study, hyper-intensity of the interventricular septum, which is the interventricular septum sign, which might denote that this patient is also going into anemia, okay? So it's a consumption cardiomyopathy state. So take care. I would say that since you've reached the diagnosis and it's a bleeding issue, then go right away for surgery because this condition is devastated. It has also reached the other side of the retroperitoneum, okay? But very well described and you've reached the diagnosis very well. I'm just fine tuning because, you know, I want to tell you everything.
Yes, yes.
This one, made lung, just go back to the made lung on Radiopedia, you will find that usually made lung deformity, if it is congenital or a part of a syndromic disease, remember that the ulna will usually have a positive ulnar variance, not a negative, okay? And remember, it's the V-shaped appearance of the corporal bones, but in this patient, the distorted appearance and the destruction of the distal ulna gives you the impression that it's probably something like a previous trauma or a previous infection that has happened in this area and has caused this deformity, okay? So in this case, remember, it's a positive ulnar variance, not a negative. And as you correctly mentioned, the V-shaped configuration of the corporal bones. And this looks like a very close appearance. So in this case, you wouldn't call it a made lung, you would call it a pseudo made lung deformity, okay? So made lung deformity. And remember, as you correctly mentioned, I will look on the other side and I will also check any previous radiographs. The syndromes that are commonly associated with this is the Olier's disease, and it's also the mucopolysaccharidosis, okay? And one more, which I forgot at the moment, okay?
Yeah.
Okay. So this one was excellent, actually. You did very, very well in it. And I just wanted you to go a little bit upwards and check since you were telling me that it's at the jugular bulb, if you would have gone a little bit up, you would see that it has extended into the middle ear, okay? Even the external ear, it has eroded parts of the long process of the incus, and it has also eroded the inferior semicircle canal is also eroded, and even see here, it's approaching into the cochlea. So this patient, if you go back to the history, you would see that the patient was presenting with a left-sided sensory neural hearing loss, okay? So this explains the finding. So just go up and down, do not stop at a point and keep describing, and you haven't seen the entire examination because this is something all of us do in the exam and even in our Viva sessions. So just make sure to check up and down all the extent and then stop describing. Okay.
Okay. Thank you so much, Dr. Maha. Excellent session and a lot of energy and efforts put into it. Thank you very much. Thank you very much.
All, and I really wish you all the best of luck.
Thank you.
Welcome. You're welcome.
Good night, everyone. Good night.